Good afternoon, everyone. We're going to be starting shortly. Just going to give everyone a chance to join before we start today's presentation. Hello, everyone, and thank you for joining us today. My name is Ruthie Marker. I'm the Education Program Manager of the Allergy and Asthma Network, and I'm thrilled to welcome you to today's presentation. We have an exciting session, and I'm delighted to introduce today's presenter, Dr. Jared Darveaux. With his extensive knowledge and experience in allergy and immunology, we're in for an enlightening and instructive session. Before we start today's program, we do have a few housekeeping items to review. First, all of our participants will remain on mute during the webinar. We will record today's session and upload it to our website within a few days. You can find all of our recorded webinars at allergyasthmanetwork.org. Please scroll down to the bottom of the page to access those recording webinars and any upcoming events. Our webinar will run for 1 hour, including a dedicated question and answer session. We will address as many questions as possible at the end. However, you are welcome to submit those questions at any time during the presentation using the Q&A box located at the bottom of your screen. A team member will be actively monitoring the chat for any questions or should you need any assistance. We will strive to answer as many questions as possible before we conclude today's session. This Advances webinar is sponsored in partnership with the American College of Allergy, Asthma, and Immunology. ACAAI offers CMEs for physicians and attendance credits for all others. You can create a free ACAAI account and obtain a CME or attendance credit through their member portal for Advances webinars. All attendees will receive a certificate of attendance. No other continuing education credit is provided. A few days after this webinar, you will receive an email with supplemental information and a link to download the certificate of attendance. We will also be adding the link to the certificate attendance in the chat, so keep an eye on that. So let's go ahead and get started. Today's presentation is titled The Basics of Biologics. While ordinary drugs will always have a place in healthcare, biologics are, in many ways, the future of medicine. Scientists are using biotechnology to target diseases more precisely, effectively, and often with fewer side effects. Research continues to refine this technology and develop new treatments for new conditions. It is my pleasure to introduce today's speaker, Dr. Jared Darveaux. Dr. Jared Darveaux is a specialist in allergy and immunology. He serves as the Department Chair of Adult Allergy and Immunology and the Medical Director of Pharmacy for Emplify at Gundersen Health System in Onalaska, Wisconsin. Dr. Darveaux earned his undergraduate degree in biology from St. John's University in Collegeville, Minnesota. He completed his medical degree and his internal medicine residency at the University of North Dakota School of Medicine and Health Sciences in Grand Forks, North Dakota. He then went on to complete his allergy and immunology fellowship at the University of Wisconsin Hospital and Clinics in Madison. Currently, he is a member and serves on several committees for the ACAAI, including the Asthma Committee and Abstract Review Committee, and he is the Vice Chair of the Biologics and Pharmacology Committee. Additionally, he participates as a member of the AAAAI Immunology, Allergen Standardization, and Allergy Diagnostic Committee. He's board certified by the American Board of Internal Medicine and the American Board of Allergy and Immunology. Dr. Darveaux's medical interests include asthma, allergic rhinitis, and other atopic conditions with a particular focus on biologic medications. So with that, thank you for being here again, Dr. Darveaux. I will turn it over to you.
Great. Thank you, Ruthie, and thanks for everyone for tuning in to today's lecture. We'll get started here. This is a slide on my disclosures. So we'll move on to the objectives. So we're going to talk about biologics today, and in particular, since most of today's biologics in our specialty are directed towards type 2 inflammation. We're going to head heavily on understanding type 2 inflammation and its relevance in atopic disease. We're going to talk about the use of biomarkers in these type 2 diseases and how to use them to help select biologic medications, and then evaluate the currently approved biologic medications for common diseases that are seen within our specialty. Talk about how they work, their mechanisms of action, and how to select an appropriate biologic for your patient. So in general, biologics are medications that are derived from living organisms. So these are usually proteins or genes. And as any of you know who have prescribed biologic medications, or maybe you're taking them yourselves, these have really just revolutionized the care of atopic conditions. They can be absolutely life-changing. So many times these are antibodies that are targeted at specific inflammatory pathways. And so for that reason, they can be very safe and effective. And they can even slow or halt disease progression in some cases, or lead to disease remission, depending on which one you're talking about. I'll draw your attention over to the left side of the screen, and you'll see just kind of a refresher on naming of biologics. The suffix mab means that it's a monoclonal antibody, and then kind of the prefix before that indicates what type of monoclonal antibody it is. So for murine, it has an O. For chimeric, it has XI, so Zimab. Zumab would be a humanized antibody, and then human antibody, and then receptor fusion. So these are the current biologics for atopic diseases. And at least these are the ones that are used most heavily in allergy and immunology practices. So you can see that some of these medications just have one indication. Some of these medications have multiple indications and can be used across several different atopic disease processes. We're going to talk about each one of these a little bit in more detail, and in particular related to the diseases that they treat. So there are several ways to kind of categorize biologic medications, or to think about how we use them. One of them is to think of them as kind of upstream versus downstream targeted medications to target those mediators of inflammation. Within the T2, or the type 2 inflammation, we have medications that target the interleukin-5 or interleukin-5 receptor, so they're really effective for eosinophilic conditions. IgE, the allergic antibody, is a target for these. IL-4 and 13 we'll talk about. TSLP stands for thymic stromal lymphopoietin. Interleukin-31 is a contributor to symptoms of itch, so we use that in atopic dermatitis. And there are, of course, other medications or other parts of these inflammatory pathways that are under investigation currently. And so as we're learning more about these different, both upstream and downstream mediators, and how they interact with different cell types, we can then use that information to select or try to develop medications that offer very targeted therapies to not only inhibit that inflammatory pathway, but also to minimize the possibility of side effects. And so some of these, this is from a journal article from 2017. You'll recognize many of these as being approved for treatment already in several different atopic diseases. But anything from things like immunoglobulins, cytokines, receptor antagonists being more downstream mediators of inflammation. We also have things like alarmins. We mentioned TSLP a minute ago, and these are kind of more of the upstream mediators of disease. So let's talk about this. Now, I kind of have a love-hate relationship with these types of diagrams. They really offer a great way to understand cell and cell interactions and different communications with different cytokines and interleukins. And that's great for us to understand those pathways so that we learn how these targeted medications work. But despite looking really complex, it is, but it's probably an oversimplification of what's actually going on in a biological system. But when we're talking about type 2 inflammation, this is originally called Th2 inflammation because it was the predominant type of inflammation from Th2 cells. We know that we can get that inflammation from Th2 cells, but there are other pathways where you can get type 2 inflammation without it being a purely allergic pathway. So there's different cell types involved in this type of inflammation. Th2 cells we mentioned, but mast cells and basophils, eosinophils, innate lymphoid type 2 cells, we'll talk about those, and then epithelial cells and antigen presenting cells. So I'm going to draw your attention over to the diagram on the right here. So in the classic pathway, when we're thinking about type 2 inflammation, we have an allergen that's presented to a Th2 cell that activates the Th2 cell, and then the Th2 cell starts producing cytokines and interleukins. Of course, that's how the immune system communicates the type of inflammation it wants to create, right? And so in the case of type 2 disease or allergic disease, Th2 cells produce interleukins 4 and 13. These are two heavily used interleukins in this process. And they have several different downstream effects. They cause B cells to isotype switch and start producing more allergic antibodies, so IgE antibody. It also causes mast cells to increase the amount of IgE receptors on their surface, so they're more likely to have be degranulated and cause allergic reactions. There are other downstream effects related to interleukin 13 on the epithelial barrier. So epithelial cells increase mucus production or mucus producing cells. And also T cells produce, or Th2 cells produce interleukin 5, and we know interleukin 5 to be one of the major contributors to eosinophil development and activation. So that's kind of the classic way we think about that. And you can have the same type of inflammation in other ways as well. So you can have epithelial-derived cytokines like the alarmins we talked about before. So that includes interleukin 25, 33, and TSLP. And that can activate a group of cells called these innate lymphoid type 2 cells. Now they're called that because under the microscope, they look like a lymphocyte, okay? They're shaped like a lymphocyte, but they don't have a specific T cell receptor like a Th2 cell does. But once they're activated, they produce similar cytokine profiles and interleukin profiles that Th2 cells do. So it produces things like interleukin 13 that, you know, from whichever pathway it comes from, can cause airway smooth muscle hyperreactivity. And it also produces interleukin 5, which can boost eosinophil development and activation like we talked about before. So looking at this, and so that was kind of using the respiratory airway as an example. On the left here, we see a similar cytokine profile when we talk about other type 2 diseases like eczema. So interleukins 25, 33, and TSLP, these alarmins can get released in the skin cells, and then they can activate dendritic cells. Dendritic cells interact with Th2 cells through OX40, the receptors called OX40 and OX40 ligand, and then that can activate the Th2 cells to produce the different interleukins that we were talking about on the previous slide. The alarmin group can be activated by allergens through through interactions with the respiratory epithelium, but it can also more generically be activated from things like viruses, bacterias, pollutants, anything that really damages or irritates the lining of the respiratory tract can cause release of these alarmins. And when it does, as we talked about on the previous slide, it can activate these innate lymphoid type 2 cells. And so that's how you can get this allergic type inflammation, even in the absence of allergic triggers. So what do we do with all this? You know, the inflammatory process, as we're seeing, is complex, it's interactive, it's redundant. There's a lot of different cell types that produce the same interleukins. There's different cell types that have the same receptors. And so that's probably what accounts for the variability in responses to general medications, maybe non-biologic or biologic medications from one patient to another. So how do we decide what's going to work for who? Well, that's where we hope to use biomarkers. So in general, if you're not familiar with biomarkers, these are traceable substances used to examine organ function and other aspects of health. So we've been using biomarkers for a long time. Hemoglobin A1C is a great biomarker for diabetes. In AIDS patients, we use CD4 T cell counts. If someone comes into an emergency room with chest pain, we order troponins to see if they're having a heart attack. And so in the context of allergic disease, the best biomarkers are used to determine the presence or absence of a disease, used to tell the disease severity and progression. You can use it as a target for therapy, and you can use it to decide whether they're having a good response to therapy or not. And it actually helps to guide about the subject's survivability or prognostic factors. So just using asthma as an example here, we kind of think of asthma as phenotypes and endotypes. So we have kind of the asthma syndrome which is characterized by airflow obstruction and bronchial hyperresponsiveness. And so we can kind of categorize this asthma syndrome through the use of spirometry. Spirometry isn't a biomarker. But then you have patients that say, well, I only get asthma when I have an infection, or I only have asthma when I'm at grandma's house and visiting and she's got cats in the house. And so then that's kind of the phenotype that we're observing. So that's where we say people have allergic asthma, exercise-induced asthma, infection-related asthma. Endotypes tie a pathophysiologic mechanism to the phenotype that we're observing. And so this is where we use the biomarkers. So we use things like IgE, either specific to allergens or total IgE. We use ENO, exhaled nitric oxide, and peripheral or sputum eosinophils to better characterize the type of asthma that we're treating. And that can help us better select a biologic. So what kind of biomarkers do we have available? Not a lot, to be honest with you. I mean, we've used IgE for asthma, and we use it in diagnosing food allergy. We know that IgE by itself is not particularly effective in treating eosinophilic esophagitis or guiding therapies in eosinophilic esophagitis. We know that eosinophils are elevated in the airways of asthmatics and can help us categorize eosinophilic asthmatics, but also it's used in diagnosis of eosinophilic esophagitis and other eosinophil-related conditions. Exhaled nitric oxide is a good marker of Th2 type inflammation or T2 inflammation in the lower airway. It's being studied in chronic rhinosinusitis with nasal polyposis, but isn't widely used currently. There's some evidence that using specific IgE to IgG4 ratios are potentially useful for management of eosinophilic esophagitis and food allergies. Periostin isn't widely clinically available, but it's another epithelial-derived cytokine that's been studied in different atopic conditions, including asthma, EOE, and atopic dermatitis. And then, of course, we use eosinophils, and we can use eosinophil proteins and inflammatory mediators to monitor disease. That's being studied in the use of management of eosinophilic esophagitis. And you'll notice that some of these biomarkers are common among a lot of different allergic diseases, so it can be difficult to decide like which one is going to be most useful for my patient. So let's start out by talking about biologics and asthma. We'll start with the oldest one, omalizumab. Omalizumab is a monoclonal antibody that targets the Fc portion of IgE, so it prevents the allergic antibody from binding to the surface of the mast cell, and then that helps to prevent degranulation and reduces allergic contribution to asthma disease. So when they were learning about this medication, or when they were developing this medication, they knew that IgE might be a good biomarker because most patients with asthma have allergic sensitization. And we know that patients with asthma that also have allergies, the allergies are a contributor to that type of inflammation. Mast cells produce histamine that causes worsening of symptoms, but activated mast cells also produce other inflammatory mediators as well. Now, we know that also IgE levels correlate with asthma severity both in adults and children, and so that made it a natural target for this disease. And so for using omalizumab, the patient selection when they designed the clinical trials initially was based on their total IgE levels, and they had to have allergic sensitization to a perennial allergen. And that makes sense because we know that omalizumab binds to IgE, but as far as using that information as a biomarker to predict whether people were going to respond to that, it didn't work very well. And so they started looking for other biomarkers that would better predict a response to omalizumab. So this is a study from 2013 where they started looking at some of these other biomarkers we were talking about. So they took patients and they put them into either a placebo arm or a treatment with omalizumab arm, and they were looking at exacerbation frequency, and they started looking at who was more likely to respond based on these biomarkers we see up here. So exhaled nitric oxide, eosinophil, peripheral eosinophil levels, and periostin, and they categorized these people into low biomarker groups and high biomarker groups. And you can see that the patients that had high biomarkers, higher ENOs, higher eosinophil levels, higher periostin levels, were much more likely to have prevention of exacerbations compared to the low biomarker group. And so although IgE is used in in dosing and insurance approval, it maybe isn't the best biomarker to use to decide whether someone is going to respond to treatment with omalizumab. So how well does omalizumab work in asthma? Well, in the right patients, it works really well. So it helps to reduce the frequency of symptoms. It helps reduce rescue medication use. It reduces exacerbation frequency. It improves lung function, and it allows for reduction in inhaled steroid dose without loss of control of asthma. So these graphs on the right are from a study from Dr. Bill Bussey looking at inner city children with moderate to severe asthma. Majority had moderate to severe asthma. And on the top side, we have days without symptoms. And really, they were looking to see if omalizumab attenuated the seasonal pattern that children often experience in the spring with allergies and in the fall with infections. And you can see days without symptoms improved with omalizumab over placebo. Number of exacerbations also improved, and you don't see that bump that you typically, or at least not as prominent of a bump that you see in the spring and the fall months. And also patients were able to overall use lower inhaled corticosteroids to maintain control compared to the placebo group. All right, so let's move on to eosinophils. We know that eosinophils are heavily involved in the majority of patients with asthma. If you look at pathology or histology slides of the lungs of asthmatic patients, you'll often see eosinophilic infiltration. Eosinophils boost the T2 response, but it can also cause, they can be elevated in the allergic side of things, but we talked about they can also be elevated in patients that don't have any allergic contribution. And once they're activated, they release their own inflammatory proteins that contribute to asthma exacerbations. So you can see elevated eosinophils both peripherally and in the airway, but it's a lot easier to collect a blood draw than it is to induce sputum or collect sputum through bronchoscopy. So we usually use peripheral eosinophilia as the biomarker in this case. So what do we know about eosinophils? We know that the higher the eosinophil levels, the more likely the patient is to have more severe asthma, the more likely they have persistent airflow obstruction, and they have increased risk of exacerbations. And we know that reducing eosinophil levels is linked to clinical improvement. So this is kind of an older study. This is from 2002, and this was a study where they looked at patients with moderate to severe asthma, and they categorized them into two strategies as far as treatment. They had the BTS stands for British Thoracic Society, and that's essentially like the stepwise approach that we use for stepping up or stepping down asthma care in the US, like in the GINA guidelines or the NHLBI guidelines. So they put them into two groups, and they had one group just manage based on the standard of care from the British Thoracic Society guidelines. The other group, they made adjustments to medications based on normalization of the sputum eosinophil count. And what they saw was the patients that were managed based on their sputum eosinophil level were much less likely to have exacerbations compared to the standard of care, about a third the number of exacerbations compared to just the standard stepwise approach. And you might say, okay, well, that's probably because these people, we know that eosinophils are really sensitive to steroid medications. They probably got more prednisone or they got more inhaled corticosteroids. Actually, there was no significant difference between either inhaled or systemic steroids in these two groups. And so that really just showed us that targeting eosinophils can have really dramatic improvements in outcomes related to asthma. So we started studying eosinophils more. So what do we know about them? We talked about interleukin-5. Interleukin-5 is like fuel for an eosinophil, right? It causes them to differentiate in the bone marrow. It helps them to migrate into tissues. Once they get to the tissues, it causes them to become activated and produce their inflammatory proteins, and it causes respiratory bursts, which leads to further inflammation. So how can we target this? There's three different biologic medications that target this pathway. Two of them, reslizumab and mepolizumab, target interleukin-5 and just prevent it from binding to the IL-5 receptor. And when that happens, the eosinophil can't get the signal to become activated and to proliferate and produce more. And so eosinophil levels kind of gradually decline relatively quickly. The other way to target this pathway is through the interleukin-5 receptor. And so that's what benralizumab does. Benralizumab is a monoclonal antibody that binds to the IL-5 receptor attached to the eosinophil. And it kind of flags the eosinophil and says to the immune system, hey, this isn't supposed to be here. And the immune system comes in with a natural killer cell and performs antibody-dependent cell-mediated cytotoxicity. So it comes in and actually kills the eosinophil. So you get rapid depletion of eosinophils, usually within just 1 or 2 days. So what happens when we start using biologics to target eosinophils for asthma? Well, a consistent feature of this is that they reduce exacerbation rates. And so on the right here, you can see this is a study looking at mepolizumab versus standard of care or versus inhaler medications alone. And you can see that reducing eosinophil levels through binding to IL-5 reduces exacerbations by about half. Interestingly, whether the patient has atopic disease or not, or has allergic disease, I should say, has no impact on whether they respond to mepolizumab or not. But the most impressive responses are seen with people with more eosinophils around. So this is one where a high eosinophil count peripherally would be a good biomarker to predict a good response to mepolizumab or an IL-5 targeted agent. On the left, we see just kind of another way of looking at similar data. We see the patients on the far left in the mepolizumab group were much more likely to have 0 exacerbations, and the patients that had placebo were more likely to have multiple exacerbations. So let's talk about interleukin-4 and interleukin-13. We talked about this earlier, and we know that these are heavily involved in allergic and atopic disease. So the primary source is Th2 cells, but you can get it from other cell types like we talked about. So again, this is using the airway as an example, but in the airway, it increases goblet cell production and activity, so you increase mucus production. It can cause naive T cells that haven't decided what type of terminal T cell they're going to be to become Th2 cells, so it kind of boosts that response. It increases adhesion molecules in the vascular endothelium to help draw in more inflammatory cells. We talked about that it causes B cells to start producing IgE or allergic antibody rather than other types of antibody. It increases mast cell activity by increasing receptors on mast cells, which increases the allergic response. And in airway smooth muscles, it helps to, not helps, but it causes increased airway hyperresponsiveness. So all of these things that we think of as contributors to asthma, they're involved in. Why do we talk about these two interleukins together? Well, they produce a lot of the same downstream effects, and they have a little bit of overlapping effects as well. So there are 2 types of interleukin 4 and 13 receptors. There's a type 1 receptor and a type 2 receptor. The type 1 receptor is comprised of an interleukin 4 alpha chain, and then the other part of it is a generic gamma chain. Type 2 receptors are comprised of an interleukin 4 alpha chain also, but also has an interleukin 13 receptor alpha 1 chain. And so what does that mean? That means that interleukin 4 can bind and activate cells through either type 1 or type 2 receptors, but only interleukin 13 can bind to, or interleukin 13 can only bind to type 2 receptors. So initial approaches at blocking this pathway, there were a lot of different ones. Blocking interleukin 4 or interleukin 13 through consuming it with antibody. They tried using interleukin 4 receptor antagonists. They tried soluble IL-4 receptor to consume interleukin 4. They tried transcription inhibitors and receptor antagonists, and a lot of the studies initially had mixed results as far as efficacy in asthma. And it's probably because of the overlapping effects of these 2 cytokines makes targeting either one of them individually less effective. And so in comes dupilumab. So dupilumab is an interleukin 4 receptor blocker. So what does it do? It comes in and it binds to the interleukin 4 receptor. So it prevents interleukin 4 from binding to the receptor, but it also prevents dimerization of the interleukin 13 receptor with interleukin 4. So it prevents activation of the type 2 receptor as well. So when they started studying this in the context of asthma, I'm going to draw your attention down to the left lower part B down there. And so this was a study from Dr. Sally Wenzel in 2013. And what they did is they took moderate to severe asthmatics, and they were on inhaled steroid plus another mostly long-acting beta agonists. And they entered them into the study. And 4 weeks into the study, they withdrew their long-acting beta agonist medications. And they started, well, from the beginning, they were following exacerbation rates. And maybe not surprisingly, the placebo group started having exacerbations. And then 2 weeks later, they took away the inhaled, or they tapered off inhaled corticosteroids. And not surprisingly, the placebo group really started to have higher rates of exacerbations, which continued throughout the end of the study. But look at what happened with the dupilumab group, very marginal increases in exacerbation rates. So what does that mean with some of these biomarkers we were talking about? Exhaled nitric oxide. Well, nitric oxide levels in the placebo group didn't really change with removal of a LABA, which isn't surprising, but when you took away the glucocorticoid, not surprisingly, the ENO levels go up. ENO levels in the dupilumab group went down and stayed low throughout the rest of the study. Similarly, eotaxin, which is an eosinophil chemotactic agent, didn't change much with the placebo group, but went down with the dupilumab group and continued throughout the study. And total IgE levels, you wouldn't expect to change with alterations in inhaler therapy, and it didn't. But you can see that after treatment with dupilumab, IgE levels went down and continued to trend down throughout the study. So I've mentioned exhaled nitric oxide on a couple of occasions through this talk, and it is a useful biomarker for type 2 disease. So nitric oxide is something that everybody's respiratory epithelium produces, but in the presence of type 2 inflammation, that number goes up and they produce more. And so it correlates with sputum eosinophilia, and like eosinophils, a high ENO level increases the risk of exacerbation. So I use this frequently in my clinic. In fact, the American Thoracic Society has said that ENO levels have been shown to predict the likelihood of responsiveness to inhaled steroids more consistently than other things that we use to measure asthma, like spirometry, bronchodilator response, peak flow variation, or response to methacholine. So we thought initially, great, we know that eosinophils and ENO levels are consistently elevated together. So we're going to use eosinophil targeted agents, and we're going to see those ENO levels go down. And that's what we expected when we started studying these monoclonal antibodies that target eosinophils. And so this is a study with mepolizumab. And you can see that when they follow blood eosinophil counts, the eosinophil levels drop once you start mepolizumab, and they stay low throughout the study where they don't change in the placebo group. But look down here at the exhaled nitric oxide levels. They don't really change all that much despite reduction in eosinophil levels. So what does that mean? It means that ENO is not a surrogate marker of eosinophilia. It's a marker of type 2 inflammation in general. And reductions in ENO from inhaled corticosteroids aren't just reducing eosinophils, it's more broadly reducing type 2 inflammation. All right, so let's talk about thymic stromal lymphopoietin. So this is one of those alarmins we were talking about before. This is an epithelial-derived cytokine. So it's released when any sort of insult happens to the respiratory epithelium. And it's one of those upstream mediators because it can affect several different kinds of downstream mediators, not surprisingly. On the allergic side of things, it can contribute to allergic disease through secretion of interleukin 4 and 13 and IL-5. So it contributes to both allergic inflammation and eosinophilic inflammation. However, in those patients that don't have eosinophilic or allergic disease, it also contributes by having receptors on mast cells that can cause activation of them in that way, on smooth muscle cells, and on fibroblasts. So it's thought that TSLP may contribute to some of the remodeling that we see in asthmatics over time. Initially, when they were studying tezepelumab, which is a biologic that targets TSLP, they noticed that, man, it seems like, I'm going to draw your attention to on the left here, they're looking at exacerbation rates. The gray is the placebo, and then these groups are different doses of tezepelumab. And they noticed a fairly dramatic improvement in exacerbation rates, regardless of whether they had low or high eosinophil counts. low or high ENO status or low or high Th2 status based on allergic contribution. And so that's kind of how they presented this this medication initially, is that biomarkers really don't matter. You can just prescribe it for anyone. However, even within the same study, we did see that the biomarkers, this is just looking at ENO, we know that those T2 biomarkers do decline with use of tezepelumab. So what do we do with that information? Well, subsequent studies have really shown that while tezepelumab is helpful in both T2 high and T2 low asthma, the patients that have more Th2 or T2 inflammation are more likely to benefit or have more likely to benefit from tezepelumab. So this is a study looking at responses to tezepelumab, and they separated them into T2 high and T2 low groups. So this is the total population up here, and then down here we see patients with greater than 300 blood eosinophils and with allergic sensitization, and then they included whether or not they would qualify for treatment with omalizumab as well. And you can see that although the total population benefits, the patients with Th2 disease showed a little more pronounced benefit than the total population. And you can see this on the right as well. So the blue is the placebo group, and again, they're looking at annualized exacerbation rates. And in the placebo group and the tezepelumab group, you can see that this is the total population. There was a significant reduction in exacerbations. If you look at patients with less than 300 eosinophils, they were still likely to have exacerbation reduction, but it wasn't nearly as pronounced as the exacerbation reduction in patients with blood eosinophil levels. So it just shows that T2 high patients are a little bit more likely to benefit from tezepelumab than T2 low asthmatics. All right, so that was a lot on asthma. We're going to kind of shift gears into talking about eczema for a little bit. So there's several different tissue or serum biomarkers that aren't quite ready for clinical practice yet, but they are being studied currently. So some of the potential predictors of responses to medications, if patients have CCL2, this is a tissue marker, they're more likely to respond to a lot of different type of therapies. CXCL2 is expressed on Th17 cells, and patients that express higher levels of that are more likely to respond to dupilumab. Interleukin-22 expression can predict likelihood of response to fezikinumab, which isn't quite available for practice yet. And DPP4 and periostin. Periostin we talked about earlier as an epithelial-derived cytokine. These patients are more likely to respond well to tralokinumab. So let's talk about the biologics that are available for eczema currently. So there's two biologics, tralokinumab and lebrikizumab, that target interleukin-13. And interleukin-13 is involved in the similar way that we talked about it with the respiratory epithelium. But more specific to the skin, interleukin-13 can cause downregulation of filaggrin, which increases barrier dysfunction, and that can perpetuate or exacerbate disease. And we've already talked about the mechanism of dupilumab, so it blocks both interleukin-4 and interleukin-13. And so just to give you some information on how well it works for eczema, this graph is specifically looking at results related to a study with dupilumab, and they're looking at something called the EASI score. The EASI score is the eczema area and severity index. It's a scoring system from 0 to 72, and you look at different body parts at the extent of disease and the severity of disease. And so one of the outcomes you can look for in these clinical trials is what percentage of patients improved their EASI score by 50%, by 75%, or by 90%. And so that's what we're looking at. And you can see the placebo group didn't do as well, but both of the dupilumab groups had 80% or around 80% improvement, 50 in their EASI 50, in their EASI 75. Almost 70% of patients were able to achieve that, and almost a little over 40%, and at the end of the study, close to 50% were able to have 90% clearance of their skin. Another outcome measure to look at when we're talking about eczema is symptoms of itch. So pruritus scale, there's different ways of measuring this. For the most part, they just give the patient a 0 to 10 scale, kind of like you use on a pain scale, and you say, pick a number, how itchy are you? And this is the percentage reduction in the treatment group with dupilumab compared to the placebo group. And any of you that have prescribed dupilumab for eczema know that, again, this can be just a life-changing medication for these people. This kind of shows the progression of improvement in 3 different patients over the course of several weeks after treatment with dupilumab. Nemolizumab, also approved for treatment in atopic dermatitis. This targets interleukin-31. So interleukin-31 can also be released by Th2 cells, and 31 is the primary mediator of itch. So it binds to peripheral neurons and causes symptoms of itch. And so nemolizumab used in atopic dermatitis, we're looking at a study looking at some of the outcomes. The VAS score is, again, the visual analog scale. That's, again, similar to the pain scale. It's a marker of symptoms of itch. And we're looking at, let's look at panel B here, because this is only 15 days into treatment. And you can see that patients' symptoms of itch improve dramatically after only 15 days. 16 weeks out, you can see that that trend continues. And the EASI score we talked about on our last slides, we see improvements in the nemolizumab group as well. And then the ISI score is the insomnia severity index. So patients with severe eczema often have problems with their sleep. And there's an insomnia index, which is on a scale of 0 to 28. Less than 7 is considered normal. And so the patients with a score of less than 7 were much more likely to be in the nemolizumab group compared to the placebo group. Moving on to urticaria, omalizumab is the only biologic that's approved for urticaria. It reduces IgE, which decreases survivability and proliferation of mast cells. It reduces the stimulus, or increases the stimulus threshold needed for degranulation and activation of mast cells. So it improves outcomes in patients with chronic spontaneous urticaria who fail type or H1 antihistamines. Interestingly, as far as biomarkers are concerned, low IgE, low eosinophils, and low basophils are predictors of poor response to antihistamines and treatment with omalizumab. As far as how well omalizumab works in urticaria, you can see this is the yellow is the approved, FDA-approved treatment dose for omalizumab, and we're looking at symptoms of itch and number of hives on the right. These are different doses of omalizumab or placebo at these different colors. And you can see these patients got 3 doses at day 0, 4, and 8. And you can see they had pretty dramatic improvement in their symptoms, and then they started losing that benefit once dosing was discontinued. And you see that with a similar pattern with the number of hives. Omalizumab is also approved for treatment of food allergy. Of course, you require a positive skin test and or IgE test. It increases the reaction threshold, but is not a cure for food allergy. It's being studied as an adjunct to oral immunotherapy to improve tolerability and increase dosing more rapidly and maintain higher doses. And this is a study by Dr. Robert Wood. And the primary endpoint here was whether or not patients were able to tolerate peanuts. So they had to enter the study, they had to react to less than 100 milligrams of peanut. They also followed other outcomes related to other foods. They had to have a reaction with less than 300 milligrams of one of these other foods, cashew, egg, milk, wheat, hazelnut. And then they started on omalizumab or placebo, and they came back, and if they were able to tolerate at least 600 milligrams of peanut, that was the primary endpoint. And then secondary endpoints were tolerating 1,000 milligrams of one of these other foods. And you can see in the treatment group, they were much more likely to be able to tolerate that than in the placebo group. So a good protector from developing allergic reactions. Chronic rhinosinusitis with nasal polyposis. So there are 3 biologics that are approved for this: dupilumab, omalizumab, and mepolizumab. All of them have been shown to improve symptoms and polyp burden and reduce need for surgery and systemic steroids compared to placebo. There are no head-to-head studies that I'm aware of, but there was an indirect comparison study, and that's what we're looking at on the left here. In this chart, they were looking at different outcomes related to nasal polyps. So quality of life, sense of smell, rescue corticosteroid use, need for surgery, and then score size based on polyp amount and size. And so you can see dupilumab, the green means it works really well for it. Dupilumab worked really well in all of these categories. Next best in this study anyway was omalizumab, followed by mepolizumab. Right now, we don't have any biomarkers available for nasal polyposis, but nasal exhaled nitric oxide is being studied. All right, so how do you decide now? We've gone through several disease processes. How do we know who to choose for what, or what to choose for who? Part of it is using those biomarkers like we talked about. We went over like which patients are more likely to respond depending on really high biomarker levels. But for me, you know, a lot of the time I think about comorbid disease. If I can use one biologic medication to treat 2 or even 3 different disease processes, I'm going to choose that one. You can use biomarkers like we talked about. You can talk to your patient about disease exacerbating factors. So if your patient says, you know, I really don't have problems with my asthma except during pollen seasons or, you know, around certain allergy triggers, you know, in that case, maybe omalizumab would be a better choice than some of the other biologics. Of course, patients are always worried about side effects, and you'll have that discussion with them. Dosing frequency is important for some patients. So some of these biologics are dosed weekly, biweekly, monthly, or every 2 months. And there's some that are coming out that are even less frequent dosing than that. Some patients take comfort in knowing that some of these medications have been around for a long time and we have a better idea about long-term safety and efficacy. Patient preference is always, you know, that's conversation happens with every patient. And then of course, more often than we like, insurances can help dictate which medications we choose based on coverage. So what's in the pipeline? What's coming down the line? So depemokimab is an IL-5 targeted agent that's going to be an every 6-month dose medication that's going to be looked at for asthma and nasal polyposis. Fazikinumab is being studied for atopic dermatitis. It's an interleukin-22 cytokine. Interleukin-22 promotes epidermal hyperplasia and inhibits skin barrier function, so that's why it's being used there. Nemolizumab we talked about for atopic dermatitis, but it's being studied for other pruritic conditions. Tozorakimab is an interleukin-33 being studied for different respiratory disease. Itokimab is interleukin-33 also being studied for atopic dermatitis. Rademikibart is interleukin-4 receptor alpha, similar to dupilumab, being studied for atopic dermatitis. So is eblasakimab, easy for me to say, interleukin-13 receptor alpha. We talked about briefly OX40 and OX40 ligand involved in atopic dermatitis, and there's 3 medications that are being studied to target that pathway. And then barzolvolimab is a tyrosine kinase KIT inhibitor being studied for chronic spontaneous urticaria. So if you ever want more information, the American College of Allergy, Asthma, and Immunology has a toolkit that has a biologics cheat sheet, or biologics at a glance, and they have, this is an example of it for tralokinumab. It tells you about what the medication is, how it works, what it's indicated for, different dosing strategies and side effects and things like that you can look at. So it's a great source of information if you're looking for specific features of these biologic medications. So summary, so biologic medications have really just revolutionized the management of allergic diseases. Some of these disease states, we have biomarkers that can help us select certain biologic medications that are more likely to be beneficial for patients. And really, you know, understanding the underlying pathology and the interactions between cells and interleukins and different cytokines helps us to decide which medications are more likely to be beneficial for our patients. So we're really, you know, having targeted therapy at that point, or personalized therapy. So that's all I have for you today. I'm happy to answer questions. I appreciate your time. And I'll turn it over to Ruthie for the question and answer session.
Awesome. That was so great, Dr. Darveaux. We do have lots of questions, so we will answer as many as we can. Let's see. The first question that came in was regarding biomarkers for chronic sinusitis. The question is kind of tailored toward, is that because there isn't enough research yet on chronic sinusitis?
I think that's part of it. And I think part of it is that they haven't found biomarkers that have consistently been shown um, to predict outcomes related to the biologic medications that we're using currently. The biologics that are available, all three of them work in very different ways. And so that can make it difficult for one particular biomarker to be a predictor of response to you know, all three different biologics. So
Okay, awesome. Next question, considering the risk for hypereosinophilia with dupilumab, do you have a max EOS baseline cutoff for which you would not initiate dupilumab for asthma, or just monitor for initiation if the baseline is very high?
that's a great question. And you know, when they were doing the initial trials for dupilumab, the other thing to take into consideration is they excluded patients with high eosinophil counts in their initial asthma studies. And so they did notice that patients with that started dupilumab, there were several of them that had transient increases in eosinophil levels. Those usually normalized as they continued throughout the study. My feeling is that, and then some patients actually were found to have things like hypereosinophilic syndrome or eosinophilic granulomatosis with polyangiitis. Those latter situations, my suspicion is that those patients had those diseases probably underlying, and starting dupilumab simply unmasked that. That being said, I don't have a hard cutoff. But I will tell you the mark that they used in the clinical trials was 1,500 eosinophils. And so when patients have baseline levels above that, then I start thinking about maybe using an eosinophil targeted agent rather than dupilumab. That can be tricky in the context of EGPA because the eosinophil targeted biologics, like we showed earlier, weren't as effective in treating nasal polyp disease. And so, you know, in that case, dupilumab would be maybe, like I said, if I can treat more than one disease at once and patients have both asthma and nasal polyposis, I'm going to try to treat both of them with one medication. So if you have a suspicion for an underlying eosinophilic process that's maybe separate from the disease that you're actually treating, it wouldn't be wrong if you're going to start dupilumab to check eosinophil counts afterwards, or only check them if you feel like they're not responding or developing other features of those disease processes.
Awesome. Thank you for that. We have another question. It is related to pheno. The question is, can you talk more about the use of pheno in your clinic? Do you obtain levels on every patient, or only as an aid in treatment decisions, or do you evaluate levels during an exacerbation?
Um, Different, so yes, in certain situations to all of those things. So when I'm seeing patients for an initial evaluation, I usually check a baseline ENO level to see really how much ongoing inflammation there is, regardless of what kind of treatment they're on. You know, sometimes patients are on medium or low dose inhaled steroid and they still have ENO levels that are, you know, significantly elevated. They might respond to higher doses of inhaled corticosteroid. We know that ENO levels rise quickly after someone stops their inhaled corticosteroids. So it's also a good tool to use to monitor adherence. So if I have a patient come in and their ENO is 150 and I start them on inhaled steroid and they come back a month or 3 months later and it's, you know, still 150, sometimes I'll call the pharmacy and say, hey, are they filling that? And if they're not filling their medication, now you're having a very different discussion with that patient. You're not talking about lack of efficacy, you're talking about adherence to medication. I don't generally check ENO levels during exacerbations because I think, you know, either I expect it to be high or it's not really going to alter my management decisions all that much. And as far as monitoring throughout uh, if patients are kind of gradually having worsening spirometry over the course of months or years, sometimes I'll throw in an ENO level just to check and see, hey, is there some other inflammatory process, or do we have worsening disease going on despite, having been stable previously? So I don't
Thank
check it
you.
on every patient on every visit, but I'm not shy about checking it either.
Great. We have time for one more question. This is in regards to safety during pregnancy. The question is, for atopic dermatitis and nut allergies, are any biologics safe during pregnancy?
So this occurs frequently. We have this conversation frequently with patients. There are no studies that use pregnant women in their clinical trials, and so we know that these biologic medications are antibodies, and we know that antibodies are transferred across the placenta, and so baby is exposed to them. And this predominantly happens during the third trimester. Of the medications that are available, there's a website called mothertobaby.org, and that follows patients who have either started biologic medications during pregnancy or have continued on biologic medications after becoming pregnant. And so that at least gives us some retrospective data on safety and efficacy of those medications. So far, of the medications that are available for atopic disease, there aren't any known detrimental effects to the baby. Of the medications that are available, both omalizumab and dupilumab are available for treatment all the way down to 6 months of age. I understand that a 6-month-old is not the same as an unborn child, but we do have good safety and efficacy data in that population. And so I just make sure that I have that conversation with patients saying that, look, we don't have specific data during pregnancy, but we have good data that it's safe for 6 months old and above.
Thank you so much. Lots of great questions. Thank you again for this presentation. I hope everyone had a great time and was able to walk away with some answers to their questions. Zoom will be emailing you in a few days with a link to this recording, an evaluation, and supplemental resources. I would also like to share some upcoming webinars that we have that we hope that you will attend and enjoy. On April 24th, next week at 4 p.m. Eastern Time, we invite you to join us for our Unidos Hablamos Series 5 on chronic urticaria in the Hispanic and Latino community, titled More Than Hives. In this special session, Stella Martinez will share her story and journey living with chronic urticaria. Join us as we learn more about how living with chronic urticaria has taught her resilience and determination. We do hope that you're able to attend and connect during this meaningful conversation. Then on May 13th at 4 p.m. Eastern Time, join us for another engaging and informative Advances webinar on eosinophilic esophagitis, Understanding and Managing the Condition, presented by Dr. Jay Lieberman. In this session, we will provide a comprehensive overview of eosinophilic esophagitis. So please join us as we delve into the latest advances in understanding, diagnosing, and managing it. Thank you once again from all of us at Allergy and Asthma Network, where we strive daily to be your trusted resource for people with allergies, asthma, and related conditions. Thank you so much, everyone, and thank you again, Dr. Darveaux.
Thank you.